Good evening, everyone. So, welcome to Mahamana Case Discussion Series. And for today's session, we have Dr. Ashok Das. He's a professor and head of the head neck surgery at B. Barua Cancer Institute, Guwahati. And he will be speaking on quality of life post-treatment in head and neck cancer patients. So, you may please share your screen.
Asim, good evening.
Good evening, sir.
Can I share my screen?
Yeah, please.
I hope you are seeing my slides, Asim.
Yes, it is seen, sir.
Okay, great. Can I start?
Yes, sir, please. You may start, sir.
Okay, thank you, Asim. Thank you, the whole team of Mahamana. And so all the delegates who has joined this webinar. So yes, so today I will speak a little bit about quality of life in head and neck cancer. It's a rather a very important topic. Very important in a sense, the treatment outcome we measure apart from the survival, the another milestone is the quality of life. So these are the two outcomes, I should say, in cancer treatment, any of the cancer treatment, and in head and neck cancer treatment. So before defining quality of life, let me touch few of the other aspects. So why do we offer a treatment? So basically increase longevity, prevent morbidity, make patients feel better. But the issue is that how to measure the patient's feeling. Some common definition of quality of life is that it is the subjective evaluation of good and satisfactory character of life as a whole. Is the gap between the patient's expectations and achievements, is an individual overall satisfaction of personal well-being, or a functional effect of illness and its therapy as perceived by the patient. So, quality of life is a general well-being of individual and societies. Quality of life is a huge prospect in the field of international development, healthcare, and mostly the policies. But we should not confuse quality of life with standard of living, which is primarily based on income of the financial aspect. So there are a lot of indicators of quality of life. It includes not only wealth and employment, but also the built environment, physical and mental health, educations, recreation and leisure time, and social belonging. So it is a multi-dimensional subject element. There are a lot of elements like elements of emotions, social and physical well-being. It's absolutely subjective. My expectation is different than the Asim Mistra's expectations or XYZ. We have different agenda and aim and objective in life. So accordingly, we have different satisfaction. So, and of course, it's not static. I should say it's absolutely dynamic. If we look into our own life, we are seeing the changes in ourselves. Like that way, if we look into our patient, and the pre-op patient, pre-treatment patient, post-treatment patient, and follow-up patient, they have different quality of life. This is what I want to highlight. Yes, so why this issue of quality of life has come? So definitely there could not be a better example than this patient who lost the mid-third of mandible because of the oral cancer in the mid-third of the mandible. The fibula have been failed. We put some plate that have been need to come. So this patient has huge issues. Even though he is alive, his life He is living with a lot of misery. He is not been able to eat properly. Every time it comes out through his mouth. His speech is not very clear. He hesitated to mingle socially. He hesitated to go attend any family functions because of his appearance. So these are some issues why it's important to discuss quality of life in head and neck cancer, particularly because head and neck cancer is we do surface surgery. Our surgeries are not like cavity surgery, like abdominal or thoracic cavity or pelvic cavity. That will open, we will do operate, we will close it like as before. It involves a lot of aspect like the appearance of the patient, a lot of functional because the head and neck area it involves a lot of special sense, a lot of special functions, starting from swallowing, speech, swallowing, appearance, lots. So that's why quality of life is a huge importance in treatment of head and neck cancer. So these are some dimensions of quality of life, like physical health. What we mean by physical health is somatic sensations, disease symptoms, treatment side effect, and I would like to say some consequences, then adverse effect. Then it's a very long treatment. It doesn't end up only patient being fed up of coming for follow-up and all. So mental health is associated with it. May vary from a positive sense of well-being to a non-pathological form of psychological distress to a diagnosable psychiatric disorder or disease. Because we know how aggressive the head and neck cancer is, and the frequency of second malignancies in upper air digestive tract or field cancerization because of the etiological factors of use of tobacco and other things. So recurrences are very common. Even if we treat with good satisfactory results, some 30 to 40% patients they come back with recurrences. So sometimes after first recurrence, after second recurrence, patients become fed up and they are mentally unstable. So mental health is associated with the quality of life. Then of course social health, just what I just say that most of the patients they hesitate to mingle socially. They hesitate to attend social functions because of the cosmetic issues, their functional issues. And of course, lastly, the functional, physical functioning like self-care, mobility, and physical activity level, social role functioning in relation to family and in relation to work. So these are some parameters of quality of life. It's a very broad subject, starting from psychological well-being, general, physical, familial, sexual, personal, cognitive, optimism and belief, importantly economic. Lot of our patients they lost their job, their livelihood, and it's a huge issue. Informational support, patient physician relationship, and of course the body image. With lot of, because as I say, the head and neck cancer in the surface surgery invariably in 80% patient whom we operate needs reconstructions, and the reconstructions of course it have impact on the body's image. So these are some parameters related to quality of life of head and neck cancer patient. Then this is how to measure somebody's feeling. So there are some instrument, we call it instrument, quality of life instrument. Some are generic like Karnofsky, then linear analog self-assessment, short form 36, hospital anxiety and depression scale kind of thing. So these are generic. So some are disease specific like URTC, very old and very widely used instrument for quality of life, mostly in cancer treatment. Then there are some other instrument as well. Then site specific, like URTC have some general domain, and site specific, like for head and neck, they have different 35. Now it's 43 patient rate for breast and etc. So subsite wise it's different. That site specific part is different. So These are different instruments by which we can measure the quality of life. So as I say, the URTC is a widely used instrument in today's world. So URTC is the oldest and largest cancer clinical trial organization in Europe. They formed the quality of life group in 1980s, long back. 15 European countries represented this group within this group as well as Australia and Canada and the USA are the member. This is a patient-based, self-administered, multidimensional instrument validated into 63 languages. Now it's more than 63, nearing 100 might be. Used more than 3,000 studies worldwide. So while quality of life C30 is an important tool to assess the generic aspect of quality of life, it has limitations, and therefore a modular approach was adopted for disease-specific treatment measurement. For example, for head and neck, it's head and neck C35. There are another separate 35 head and neck cancer specific questions for that. The first generation of core questionnaire, URTC quality of life, was developed in 1987. So cancer-specific, multidimensional, appropriate for self-administered, something like that. Then this C30 has 5 domains: functional scale, symptom scale, and single item like dysphagia, self-disturbance, diarrhea, appetite loss, constipation, financial aspect, including all. It covers all the aspects. Then head and neck 35 module, it has 7 domains. Specifically, more stress is given for pain and swallowing and speech, social contact, social eating, then sense and sexuality. There are 11 single items, starting from problem of teeth, mouth, cough, nutritional, feeding tube, weight gain, dry mouth, sticky saliva, painkillers, weight loss, etc. It covers all the aspects of a head and neck cancer patient. So there's a very complex scoring system. I will not go details about that. So high score for a symptom scale or a single item represent a high level of symptoms or problem. So by evaluating, actually we give this questionnaire to the patient like this. This is the recent one. URTC head and neck 43. So there are some questions like this. Suppose, for example, I am reading for you. Have you had pain in your mouth? Not at all, a little, quite a bit, very much. So patient will circle whatever he or she feels. So it's a self-administered. Whatever the patient feels, they will express by scoring according to their feeling. And these are some head and neck specific things, like, for example, just giving an example, question number 58. Have you had problems speaking clearly? Not at all, little, a bit, and very much. So patient will circle wherever he feels like. And accordingly, there are some scoring systems, and we find out how much the patient has some problem. So the recent one is this URTC quality of life head and neck 43. This was started yes, this was allowed to use in practical field from 2015 onwards. We are using head and neck 43. It's a very exhaustive. It has a few more questions than the head and neck 55. So this is another widely used instrument, the University of Washington Quality of Life Instrument, and developed at the University of Washington. So this is also again a self-administered instrument consisting of 12 patients, 9 disease-specific items, and 3 general items. So this is little shorter than the URTC, so it's little easier for the patients because otherwise the URTC become little exhaustive for some patients. So if we look into the studies in India on quality of life, I just have a few things I quoted um, from the article from Mr. Manus Pandey published in Psycho-Oncology. So there are few quality of studies instrument that has been developed in India, which are one was in Kerala, stress tolerance tool, then the stress inventory for cancer. Then PGI Health Dictionary by Joshi et al. In 2003 and Amritsar Depression Inventory by V et al. At PGI, Chandigarh, two tools developed in India, but these two tools have never been used for cancer. So, as because this questionnaire is self-administered, so for our Indian patient who cannot read and write English, because this URTC or University of Washington, they are in English, so that has been translated into vernacular Indian languages. So these are the standard translation procedure: two forward translation, then a provisional forward translation, then two back translation by different translator, then semi-translator, then again the final translation will have to be matched again the initial one. If both match similar, then only that has been used for pilot testing. So each translated item should be pilot test on some 10 to 15 patients. A structured interview is conducted with each patient individually to know whether it's difficult to answer, confusing, difficult to understand, upsetting, because there are some questions related to sexual habits are little upsetting or offensive in Indian setting. It's very difficult to ask. Mostly people from rural background or other. So whether the patient would have asked in a different way. So these are something we would like to know in pilot testing, and if we found satisfactory, then only the instrument is ready to use for measuring quality of life. Then the issue of validity has come. So there are reliability, how internal consistency of multi-item questionnaire. Suppose if patient has severe pain and he can sleep very well peacefully in night, then we should we should think that the evaluation is not proper, or the patient might not have understand the questions properly. So the construct validity within scale correlations, there are different scales between scale correlation. Suppose for head and neck, there are some four question on pain, so it should correlate with each other. Then criteria validity and responsiveness, ability to assess small difference within group over time. Suppose pre and post operatively, etc. Then statistical analysis, I will not go much. And I just want to put this paper, Dr. Debendra Chokar and Tipu sir, when I was doing my fellowship at Tamil Hospital. So URTC was first translated into Hindi and Marathi in 2003-4. So this is the paper for that quality of life paper. So this is at the same time we also translate and validate University of Washington quality of life questionnaire in Hindi and Marathi. My Dr. Nichols and Dr. Vivan Yahoo from University of Washington, and the Marathi and Hindi version of University of Washington quality of life appeared to be a very valid and reliable instrument for assessing quality of life in Indian populations. And after that, there are a lot of translation to different languages. In India, recently, a few years back, we translated in Assamese and Bengali here in Guwahati. And this was a quality of life cross-sectional study by our TMH team. That time, Dr. Debendra Chokar Rohan was there with us. So this was a prospective cross-sectional study in 212 patients. So what we found was that the appetite, most common symptom was appetite loss, fatigue, and cough, or those things. Then dry mouth, dental problems, sticky saliva. So these are actually we most of the time we just ignore these complaints of patients, but they are very important aspect of patients' satisfactions. Uh, this is another study by Humphrey and it was published in 2001 in Laryngoscope. So the patient with hypopharyngeal cancer reported the worst health-related quality of life. Stages appear to have a strongest impact on quality of life. Like advanced stage patient has worse quality of life. Then the female score worse than the male for the same area. Might be they have little less tolerance for this thing. And this is another study I'd like to refer that. So there's a significant deterioration of quality of life just after treatment. Of course, it improved with times, but immediately after some 3 months and 6 months study, they saw a very worse quality of life.
Hello, sir, are you there? He has some connection problem. I'll just join in a minute. I'll just get back to him.
Okay. Sorry, I might have disconnected between Asim.
Yes, sir. Yes, sir. Please share.
I'm so sorry. I don't know. This was the slide where I disconnected.
So you can please share your screen first.
Oh, I'm so sorry. Okay. 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 I'll do that. Is it okay now, Asim? Can you see me?
Yes, sir. Yeah.
I'm sorry for the inconvenience. This was the slide
No, sir. It's, just before this.
or before this? Anyway, so I don't have many more slides, so I'll just conclude shortly. So basically, quality of life questionnaire provide a medium for patient to effectively communicate with their physician in a very busy tertiary care facility and provide an insight into the physical, psychological, and social problem affecting our patients, which can then direct future intervention. Because it's not only life, it's the quality of life, basically what people expect on their physician. Just to highlight another aspect of quality of life, this is a study from, I think, China. Anyway, so what they found is that patient without a spouse had a lower utility and than those with a spouse, and patient with a low annual family income also had lower global quality of life and utility. So we are so busy with our practice that we have hardly have any time to look into this aspect. But these are very important if you see from patient perspective regarding the quality of life. So these are also very important thing. We should evaluate in pre-treatment. We also should have proper counseling, proper support for this group of patient. So what is the applications of quality of life? Quality of life can be used as an outcome measures of treatment. This is the number one thing because now I think our treatment will be measured. Can be used to assess the rehabilitation need of patient. Many times we may overlook few minor problems, but that may be a huge issue for patient. To determine the pre-treatment quality of life of patient so that quality of life can be used as a predictor of prognosis. Yes. Then important endpoint in clinical trials. In any clinical trial in oncology, you usually have two endpoints. One is survival, one is quality of life. So quality of life, as I said in the beginning, is a very important aspect of our oncology treatment. So we can use quality of life for treatment decision making, like quality of life consideration can often be important in selecting between two groups, two or more treatment options, like for laryngeal or hypopharyngeal cancer. We have two arms, surgery versus organ preservation. So we can say if we explain the different quality of life in between these two groups, then it becomes very easy for patient to choose for proper treatment protocol. Then preparing for treatment experience, then identifying and prioritizing problems. I'll not explain much here. Then facilitating communications, screening for hidden problems, facilitating shared clinical decision making, and of course monitoring changes or response to treatment. This is a little busy slide. I will not explain much. So even there are some impact of screening of cancer disease and quality of life of the patient, because by in screening, early diagnosis and treatment gives sense of confidence among cancer patients that may either be cured or if not, maybe good survival probability. And accordingly, there will be good quality of life of the patient. So, to conclude, cancer is not only affecting patients physically, but also affecting psychological, mental and social health of patient. There are various dimensions, as I described, and different models of quality of life which may be followed to ensure and measure quality of life among patients. Quality of life is not easy to measure. It's as because it's subjective. Different person has different IQ, so they will respond differently. So despite this, many researchers have coined the definition of quality of life, and certain scales are also available to measure the quality of life more objectively. Thank you very much. Thank you, Asif.
Thank you, sir, for such an insightful talk. Now we'll move ahead to for the case presentation. And today's case presentation will be done by Dr. Shruti Patil. She is a MCH resident from CMC Vellore, and she will be presenting a case on of oral cavity, CA oral cavity. And examiners for today are Dr. Dushyant Mandlik. He's consultant head and neck surgeon from HCG Ahmedabad. Welcome, sir. And Dr. Richa Vaish, she is professor, head and neck surgical oncology from TMH Mumbai. Welcome, ma'am. And Dr. Arjun Singh, he is assistant professor, head and neck surgical oncology, TMH Mumbai. Welcome, sir.
Hello.
And sir, Dr. Ashok Das, sir, I also request you to be there as an examiner in the case presentation.
Sure, thank you.
So, Dr. Shruti?
Yes, I'm here.
Ma'am, you can start now.
Yeah, I'm unable to share the screen.
Yeah, you may share your screen.
Yeah, I'm trying to share. Okay. Are you able to see, sir?
No.
1 second, sir. Okay. Can you yeah. Can you see, sir?
Yes. Yes.
Sorry. So
Slideshow. You can start the slideshow and start.
Good evening, everyone. I'm presenting a case presentation of oral cavity. It's not going up. Okay, coming to the history, here is a 54-year-old male who is a barber by profession, came with the complaint of ulcer over the right side of the tongue for the past 9 months. History of presenting illness, he noticed an ulcer over the left side of the tongue for the past, he was apparently all right 9 months back. Then he noticed an ulcer over the left side of the tongue, which was insidious in onset, gradually progressive in size. It was associated with pain, which reduced only on taking the painkiller. It was associated with referred pain to the left ear, associated with burning sensation to the spicy food. He had a difficulty in speech and difficulty in swallowing the solid food, also associated with excessive salivation, and he had a bleeding and trivial trauma like brushing the teeth. He has no history of irritation from the sharp teeth, no history of bad breath or difficulty in tongue movements or difficulty in protrusion of the tongue, no neck swelling, no history of cough with hemoptysis, no history of loss of weight or loss of appetite or bony tenderness. For these above complaints, he was evaluated elsewhere, and he underwent biopsy in the November 2023, which was suggestive of this squamous cell carcinoma grade 1, and he came here to us for further management. Past history, there are no history of similar complaints in the past, no history of any surgery in the past. Family history, no history of any malignancy in the family. Comorbidities, he has no known comorbidities. Personal history, his diet is mixed, his bowel and bladder habits are regular. Habits wise, he used to consume smokeless tobacco in the form of kini around 4 to 5 times per day for the past 35 to 40 years, and he has been reformed for the last 1 to 2 months. And he occasionally consumes alcohol. To summarize my history, there is a 54-year-old male with history of consumption, smokeless tobacco consumption in the form of kini, presented with the ulcer in the left side of the tongue for the last 9 months with significant pain, referrotalgia, and excessive salivation with difficulty in speech and swallowing, and also with bleeding and the trivial trauma. Can I
Shruti,
Yeah.
yeah, you can just go ahead, but I would just like to make one comment.
Yes, ma'am.
You have first you presented the history of the illness, and then you talked about the past history, family history, personal history, and then you came to the etiology history. What I think is that all that is positive can come up, and etiology history is very, very important. So when you talked about the presenting illness, following it could be the etiology. That is the first point, because rest of it is all negative and non-significant for you. The past history, the family history, the personal history, but etiology is important. That is one point. And second point is that probably sharp tooth you can bring it in the etiology history if you want, because when you are describing your illness and related symptoms, then when you're describing the tongue, the sharp tooth is not fitting into the presentation of the tongue. So it could come to the etiology. Like it's not there, so it can come in that no sharp tooth in under the history of etiology. So you can call it etiology history.
Okay, ma'am. I will.
Yeah, Shruti,
Yes, sir.
one more point. You said that to begin with, the ulcer was painful.
Yes, sir.
Is it a routine presentation of CA tongue to begin with painful and continue to be painful?
No, sir. Initially, there will be painless, then it can become painful, sir. Usually.
Okay.
Initially,
Yeah.
it was not such painful, but as it progressed, it was severe enough. He has to take painkillers, sir.
Okay. And second thing is that you didn't speak anything about Christmas. He was not having Christmas, right?
Yes, sir. Yes, sir.
Was any complaint of decreased mouth opening over a period
No,
of time on?
no, sir.
No.
No, sir. He has no history of difficulty in mouth opening or decreased mouth opening, either of acute onset or the past onset, sir, of long term.
Okay.
Hi,
Can I-
Shruti.
Yes, sir.
Sorry, since just to complete, if you can also just add any difficulty in breathing or difficulty in swallowing, okay? Because don't walk into the room just based on only tongue, because you know these patients can have other sites as well at the same time.
Okay.
So also breathing and swallowing would, you know, sort of complete your assessment even for the neck as well as the oral cavity and the rest of the head and neck sides.
Yes, sir. Difficulty in swallowing and breathing.
if the patient presented with that. I mean,
Okay. Okay. Can I go ahead, sir?
yeah, please.
Okay. Coming to the examination, general examination, here is a middle-aged male who is well-built, well-nourished, conscious, cooperative, and he was oriented with respect to time, place, and person. There was no pallor, icterus, or cyanosis, clubbing, or generalized lymphadenopathy. His systemic examination, respiratory, CVS, and parabdominal examinations were normal. Coming to the local examination, before that, his performance status was 1. General examination, his pulse rate was 88 per minute, BP was 130/90 millimeter of mercury, his weight was 81.6 kg, height was 170 centimeter, his body mass index was 28.2. Coming to the local examination, on inspection, he had an interincisor distance of 4 centimeter. He was partially dented, no loose, he was partially dented. Nicotine staining of the teeth was noted, and oral hygiene was poor. On inspection, there was a single ulceroproliferative growth of size 5 cross 3 centimeter noted on the left lateral border of the tongue, which was approximately 0.5 to 1 centimeter away from the tip of tongue, 1 centimeter away from anteriorly. It was 1.5 to 2 centimeter away from the circumvallate papillae posteriorly. Medially, it was reaching till the midline. Laterally, it was approximately 1 centimeter away from the floor of mouth. On inspection, the surface of the ulcer was covered with slough and the edges of the ulcer were everted. On palpation, the inspectory findings were confirmed with respect to site, size, and extent. On palpation, ulcer was indurated. It bleeds untouched. It was tender and it had a everted edges. Depth of invasion was approximately 10 to 15 millimeter. Tongue movements were normal and there was no deviation of tongue to one side and no pre-malignant lesions noted throughout the oral cavity. Coming to the neck examination, there were 2 lymph nodes were palpable in the left level 1B area, which are hard, mobile, and non-tender, and the largest of which measured the 2 cross 2 centimeter. Thyroid was not palpable. NPL-scopy, flexible nasopharyngeal laryngoscopy showed no involvement of the base of the tongue and no synchronous growth noted in the upper till the hypopharynx area. To summarize my findings, with the examination wise, there was a 5 cross 3 sized ulceroproliferative growth noted in the left lateral border of tongue, which was indurated, tender, having everted edges, and it bleeds untouched. And 2 palpable nodes were noted in the left level 1B area. And with the endoscopy, there was no involvement of the base of tongue.
So, Shruti, you categorically spoke that there was no sharp teeth, right?
Yes, sir.
Okay. And there was no submucous extension of the tumor, was it or was not?
Submucosal, yes, sir. Induration was palpable beyond whatever I could see the ulcer proliferative growth.
So you need to mention that how deep was the submucosal induration? Was it going up to midline? Was it going to the opposite side or not? Was it going in the floor mouth or not? Right?
Yes, sir. Medially, it was reaching till the midline, sir, induration.
Right. And when you have put this nasopharyngeal findings, you also need to mention that vocal cords were bilaterally mobile.
Yes, sir. Yes, sir. Sorry. Yeah. Vocal cords were bilaterally mobile, sir, actually. Is biopsy? Yes, sir.
So Shruti, okay, go on. We'll wait till you finish this and then probably ask. Go on.
No, sir. Okay.
No, we'll go back to from the start. But please finish.
Okay. His biopsy was moderately differentiated squamous cell carcinoma. Provisional diagnosis with history and examination is carcinoma left lateral border of tongue, clinically T4A, N2B, M0, stage 4A, sir. These are my imaging findings. Should I explain, sir?
Yeah, can you elaborate on your imaging finding, please?
Yes, sir. The image here shown is contrast enhanced, that is gadolinium enhanced MRI of the face and neck. First image is axial section. This is T2 weighted image, T2 weighted sequence showing an hyperintense lesion in the left lateral border of the tongue, which is extending roughly from the almost 0.5 to 1 centimeter away from the tip of tongue, reaching till the circumvallate papilla. You can tell it as up to the base of tongue is free here, and reaches medially till the midline, and laterally it is just abutting the tooth sockets. Whereas in the next image, it is a T1 image, T1 weighted sequence, coronal cuts, which is showing an hyperintense image in hyperintense lesion in the left lateral border of tongue. Here in the medially midline lingual septum appears to be free, and mylohyoid muscle appears free. Mylohyoid muscle appears free, sir. A lingual neurovascular bundle also appears to be free. It's the same MRI sequence with sagittal section showing the base of tongue is base of tongue and floor of mouth appears to be free.
So Shruti, apart from the MRI, just one thing, first on the MRI, you commented upon the midline raphe, you commented upon the neurovascular bundle and the floor of the mouth and mylohyoid. Anything other than that you can see and you would like to comment upon whether it is involved or not?
Mandible, ma'am.
Mandible, clinically, it was very far away. Other thing that you can comment upon probably is a sublingual gland or sublingual space. As you can see, it's coming close to the gland. So at least the gland needs to come out. And if it is going posteriorly, there then is a possibility of communication if the gland is coming out. So maybe it's important. And also, if it is deeply infiltrative in this region, you may think of doing a compartment resection.
Yes,
surgery part we can discuss a little later, not an issue. The second thing that I wanted to ask was two things you told us. One is biopsy, second is the MRI. My question to you is any other evaluation you would like to do in this patient?
Yes, ma'am. In this patient, I would like to do evaluation of the chest, ma'am, to rule out for the distant metastasis. It's a stage 4 cancer, so I'd like to go ahead with the chest CT scan, ma'am.
Okay. Another question that I want to ask, you said it's a painful ulcer. And what I gather from your history and your examination is that reaching the midline and laterally, I could see the proliferative component. In this case, do you think that nerve you said, I know you said you talked about the deviation of the tip. I don't recall if you talked about the movement of the tongue was normal or restricted. That I didn't notice or I missed. And I want to know, do you think there is a role of evaluation under anesthesia in this patient?
Yes, ma'am. Patients, whenever there's a painful tongue ulcers or painful oral ulcers are there, better evaluation will be under anesthesia, ma'am, to know the better extent of the lesion.
No, I understand if it is a painful lesion, and I'm talking about this patient because you told us from the tip, you told us from the circumvallate papillae, you told us from the floor of mouth, and you also very confidently told us about the midline raphe. So I want to know any role of evaluation under anesthesia, or what we have done is good enough.
No, ma'am. I would like to cross-check when patient is on table under general anesthesia because the base of tongue will be more better in the general examination will be more you will be more conclusive when I do it under general anesthesia, ma'am. Whenever I have a doubt, especially the way at the junction of the anterior 2/3 and posterior 1/3 of the area.
Okay.
Shruti, what Richa asked was examination under general anesthesia. Now, will you like to do that examination under general anesthesia before your imaging, or if required, only after your imaging?
If required, only after imaging, sir. Not always.
Right. And you have chosen MRI as your primary modality for tongue, right?
Yes,
now there are T1 weighted images, T2 weighted images, there are STIR images.
Yes,
What is the difference between them and what is the significant? And if given a choice for one single image sequence to give you maximum information, what will be your preference?
If single, sir, T1 weighted images, sir, usually give an idea about the anatomy, sir. T2 weighted images are good to look for the pathology, T2 weighted sequence, and that star sequence or like fat suppressed images will be good. Because contrast enhanced images will be the good. T2W contrast enhanced images will be the one will give an idea about the lesion, sir. And
Okay, so you will like to go for a
if there is
T2.
a diffusion weighted option, we should go for diffusion weighted imaging, sir.
Okay.
So Shruti, you said diffusion weighted. You want to do diffusion weighted for the primary or the neck nodes or both, or what do you want to do for one? Because if you've seen diffusion weighted images, now they are not very clear. They give not very nice. It's quite pixelated. So there's a specific thing that you check for in diffusion weighted images.
As such, I'm not sure of whether they do separately, sir. In our institute, we do for both primary and next, sir. I am not sure, sir.
Okay. And I'm sorry, I must have missed it, but did you mention anything about the nodes, the neck status when you spoke about the MRI?
No, sir, I didn't show here. Yes, sir.
Okay. No need to show. Did you
Yes,
mention that? So you can also mention that, whether it's unilateral, bilateral, as well as posteriorly tongue lesions when they are posteriorly. Where else can it drain? Posterior or lateral?
posterior
Any other echelon it can drain into?
retropharyngeal nodes and
Correct. So you should also look out for those. Okay, as a routine examination when you're seeing the imaging, you should also just see for those lesions. Now, Shruti, in your etiology, what do you think caused this cancer in this patient?
in this patient, use of smokeless tobacco, sir. In the smokeless tobacco is the etiological factor, sir.
Okay, and is there any pathway that you can
Yes, sir.
elaborate on for tobacco? I'll
Yes.
keep it as tobacco. I won't keep it as smokeless, but
Okay, sir. So actually, the tobacco contains more than 7,000 chemicals. In that, 69 have been proven to be more than 60 of the chemicals have been proven to be known carcinogens. These tobacco compounds have been classified into tobacco alkaloids, tobacco specific nitrosamines, polycyclic hydrocarbons. With specifically to the smokeless tobacco, there are components which includes pesticide residues, aflatoxins, mycotoxins, and also metals like cadmium, arsenic have been proven, sir. Have been there, sir. In that, in this tobacco specific and nicotine. So nicotine and it is a precursor of the tobacco specific nitrosamine compounds, sir. And to be specific, then there are compounds like benzopyrene and chemical gases like carbon monoxide and formaldehyde, and all are there in the smoke, sir.
okay, excellent. So these are the carcinogens. You enlisted them very well. Now, what do these carcinogens do once they interact with certain tissues? How do they eventually, what pathway does it follow, or do you know any of them? How does it transform into this large mass or undifferentiated cells, or how does that happen? Are there any bonds, any adducts? Have you heard of DNA adducts?
Yes, sir. They causes DNA adducts and mutations. There are 2-3 pathways, sir. Pathways I don't remember, but one is they cause DNA adducts. The second thing is they cause mutations and they cause cell cycle arrest. The DNA repair pathway will be affected, sir.
Okay, sure. So this is very important because there's very little literature on the smokeless tobacco part.
Okay, sir.
Okay, so this whatever pathway of DNA adduct, it's common because the carcinogens are common. But any addition you have seen, since you mentioned kine, patient is kine user, right? It
Yes,
just
sir.
happened.
Yes,
Yeah.
sir.
So did this patient use lime, without areca, with areca? Anything you know about that?
This person, I did not ask specifically, sir, but yeah, if but to know that people use the with arecanut, lime and all, that is called pan masala. If it is used tobacco
Okay.
leaf alone, it is kaini powder, I think.
So how does lime change the equation? What happens when the patient uses with lime?
It is an acidic component which will increase the absorption of the chemicals.
Acidic. It's alkaline. It increases the pH.
Yeah, I read,
Okay,
sir.
so
I don't remember exact mechanism.
okay, okay. And arecanut, do you know the most common thing, which I think Dushan sir was also going for, submucous fibrosis?
Yes, sir. Arecolin, many arecanut has got many alkaloids, arecolin and other things which are responsible for causing the submucosal fibrosis. The initially it will cause burning sensation, and then there will be a collagen production, and then finally it will becomes blanching of the mucosa, and then it goes for a fibrosis, sir.
Okay,
Plus bands will be.
okay, okay.
So, to add to Arjun's comment about the lime, when you are taking tobacco with the lime component actually increases the absorption of the tobacco, immediate absorption, because the pores opens up. That gives the immediate kick to the user. So that is why the lime is used with tobacco. So that is the unique combination of this region.
Okay, sir. Okay, sir.
Yeah, please go ahead.
Shruti,
Yes, sir.
you mentioned also something about radiating pain from the tongue.
Yes, sir.
Can you elaborate where it was radiating and possibly what pathway this neurogenic pain was going after?
He was complaining of pain was referred to the left ear, sir. So it is because of the similar innervation, that is the mandibular branch of trigeminal nerve, which supplies the anterior two-third of the tongue, and there is a mandibular branch of trigeminal nerve, that is a auriculotemporal nerve, supplies the external auditory canal and lateral surface of tympanic membrane. So because of the similar innervation, patient who has a pathology in the tongue, teeth, in the oral cavity, first can perceive the sense of pain in the ear, sir.
Okay, was this patient also having any problem in swallowing, or
Yes.
there was?
Yes, sir. He is to painful swallowing, sir.
Okay, sure. Go ahead.
So provisional diagnosis is carcinoma left lateral border of tongue, clinically T4A, N2B, M0, stage 4A, sir.
So can you tell us why it's T4?
T4 because of the size of the tumor more than 4 centimeter, and expect depth of invasion is more than 1 centimeter, the stage it becomes T4A, sir.
Okay, and why 2B in this situation?
Because I was able to palpate 2 lymph nodes in the level 1B area, sir.
Okay, so when you can palpate this, could you differentiate whether it was inflammatory or whether it is infective, or whether it is the cancer metastasis?
Yes, sir. Because it was non-tender and hard, it's more likely metastatic. Inflammatory nodes are also common because of the poor oral hygiene, but they will be usually tender, sir.
Yes. So in your answer now, you should always say it is the clinico-radiological assessment that led you to say that this is metastatic node, not because you felt 2 nodes.
Yes, sir.
Okay, so yeah, so your overall assessment led you to the point 2 nodes, which can.
Not audible, sir.
Yeah, sorry. Go on, please, Shruti.
Shruti, just to continue the same discussion. So you talked about the clinical features of the metastatic node. Can you tell me the features on MRI that would prompt you to say that these nodes are metastatic?
An MRI node shape of the node will be rounded, ma'am, and it will be hyper intense. Then there will be loss of fatty hilum. then there can be a central necrosis, ma'am.
And size is any criteria?
Yeah, size wise, it should be more than 1 centimeter or 10 mm in the other levels, but in the level 1 and jugular digastric, it should be more than 15 mm size criteria.
Okay. So the staging you have done now, how will you treat this patient?
Ma'am, in this patient, first I would like to investigate. Already I have done an investigation and I have confirmed his diagnosis by biopsy, ma'am. So I would like to go ahead with the plan for surgery, investigations for the fitness for the surgery, then followed by fitness and surgery for this patient, ma'am. Investigations for a fitness for a surgery, I'd like to do complete blood count, renal function test, echocardiography, 2D, ECG, and then blood sugar levels, and I will get a pre-anesthesia fitness. Following this, I will be assessing, be taking up. I would like to go ahead with the surgery, sir. Before that, I would like to include. Include a dental prophylaxis for this patient and nutritional assessment, as well as pain management for this patient, ma'am.
Okay. You tell me the
following evaluation. Sorry.
Shruti, you have planned surgery for this patient and you are going for all this investigation. You are taking this patient for OT.
Yes,
But how you will counsel this patient about the treatment? What counseling is essential for this patient when you are going to treat him?
Yes, sir. Yes, sir. Counseling is essential because patient will have an idea what to expect in the post-operative period and as well as the outcomes of the treatment. I would like to counsel him that, tell that the treatment of choice for his malignancy will be the surgery and plus followed by adjuvant treatment in the form of radiotherapy with or without chemotherapy. That will be the complete treatment for him. And so that patient will have an idea that the just surgery itself is not an complete treatment. Then I would like to tell him that his speech and swallowing in the post-operative period will be not like a pre-operative status. There will be some changes in this speech quality as well as in the swallowing thing in the post-operative period. And also I would like to inform him about the complications, expected sequelae and complications which are part of the surgery and need for the adjuvant treatment, sir.
Okay, Shruti, when these patients come to you, usually they will ask you some leading questions. So you told about the treatment part, you told about the sequelae, but they would also want to know what is the chance at cure, and they would also want to know the extent of resection, and usually what would you do for the reconstruction. So based on whatever you have told us so far, at least add these 2 points as well, please.
Yes, ma'am. I will tell him that the extent of surgery, that how much of the tongue, like at least I can tell you that 2/3 of his tongue or 1/3. In this case, at least almost 2/3 of the tongue will be going. So I will explain him that his 2/3 of the tongue has to be taken out to give a clear margin. And then after removing the tongue, he will be needing a reconstruction of that space. So that then the options which I can give him an option, best option with starting with the 3 flaps, radial forearm flap or lateral arm flap or anterolateral thigh flap. Then other options like local and regional flaps for him. Followed that, expectation wise, I will tell him that it is for a completion of the after completing the treatment, he has to be on a regular follow because the because of the advanced stage, his chance of tumor recurrence will be high. That is around 40 to 50% of the patients in stage 3, stage 4 will have a recurrence. So he has to be on a regular follow-up very strictly once in 3 months for the first 2 years, and then once in 6 months for the next 5 years. And after 5 years, once in a year for lifetime.
Would you explain about the need for the neck dissection and also the problems with the neck dissection? Because you just talked about tongue.
Yeah, yes, yes, for me, I will also explain him about that. He needs a neck dissection because it is a stage 4 and he has a palpable metastatic nodes. And I will also explain him that the neck dissection he requires on the contralateral side also because his tumor is reaching till the midline.
So, Shruti, what is the extent of neck dissection you will do?
Sir, in this patient, bilaterally selective neck dissection level 1 to level 4, I would like to do, sir.
You said that is 2B, right?
Yes, sir. Actually,
N2B.
yes, sir. Yes, sir. If it was a level 3, level 4 area, probably I would have done for an MRND in the ipsilateral side and level 1 to 4 on the contralateral side. But 1B, I feel still I can go ahead with level 1 to 4 bilateral.
Any evidence you have for this that says that in an N plus neck in level 1B, you want to do only 1 to 4?
N plus neck, yes, sir. Evidence paper has been published. Even in the N1 neck, we can go ahead with the oral cancer level 1 to 3, level 1 to 3 for the other sites. Level 1 to 4 for the tongue will be sufficient, sir.
This is N2,
Shruti,
right? Not N1.
Yes, sir.
okay.
So in an
One more thing.
There is a
Please.
question in the chat box. Sorry to interrupt. If somebody can read that.
in a CA tongue, should you do MRI or biopsy first, and why? Shruti?
Yes, sir. In CA tongue, I should do first MRI and followed by biopsy, sir. Because if
Why?
biopsy is done first, there is a high chance that there will be a lot of edema and that will be picked up and, give a wrong extent of the disease.
Okay, fair.
So, Shruti,
So,
it is not sacrosanct what you said. In a CA tongue patient with the tumor, which the size you are telling us, 5 centimeter tumor, a small tissue from the margin is not going to change anything. You will have a biopsy as well as you can go ahead with MRI. While having a very small tumor, let us say a 0.5 centimeter or 5 millimeter or 1 centimeter tumor, which is doubtful that it is malignant or not, and you are going for that investigation. In those cases, to do an MRI first and then do a biopsy is better, because then the edema can skew the aspect, skew the images. So it is not always sacrosanct that do the MRI first and then biopsy. You have to see that edema is going to hamper your further management or interpretation or not.
Okay, sir.
Okay, and Shruti, going back to the extent of the neck dissection that you were commenting. So, you first tell me a thing that if it's a tongue, what is the most common level of the neck node that is involved? That is my first question to you.
Level 2 mm.
Level 2 is usually the, so was it categorically a level 1B that you were commenting? It could also be at the junction of level 1B and 2, which is like a 2A. So when you said that you would just do level 1 to 4, I'm not very sure that would be the best idea. Second thing is, you said it is level, it is say category N to B. So it's not just N1, it's not a small node. You are palpating 2 nodes, you are seeing it on the MRI. So maybe in this case, especially if it's a 2A node, multiple nodes, probably clearing out level 1 to 5 would be a safer option with such a large tongue, because tongue has a very high chance of lymphatic metastasis and it's notorious for recurrence in the neck. Had it been a small buccal mucosa, I probably would have agreed on what you said, but I would suggest going ahead with a neck dissection, completely clearing level 1 to 5 on the ipsilateral side. Contralateral side could be elective if there are no palpable neck nodes.
Okay. This was okay. Little doubtful for me also whether I should do MRND, SND. Actually, I had that
No,
idea.
if the nodal burden is high, if the ENE is there, it's a large tongue, level 2A metastasis, large manifesting 2A metastasis. In those cases, it's better to clear. That is the indication to clear out level 5. If you have a small node, something occult metastasis, a small buccal mucosa primary, you can still spare level 5. So I think this patient had many indications to suggest better to clear out level 5.
Okay.
so
Prithvi, what
Shruti,
will be?
sorry, go
Yeah,
on, sir.
Arjun. Yeah, Arjun,
No,
please
no,
go
go
on.
on, sir.
So, Shruti, what will be your sure shot indicators where you will 100% go for an contralateral neck dissection?
Tumor involving the tip of tongue, sir. Tumor crossing the midline of the tongue. Tumor involving the base of tongue and floor of mouth involvement and level 1A significant 1A node. These are the short indications to do contralateral. And imaging, if there is a obvious contralateral node which can be suspicious or confirmed, can go for a contralateral neck resection.
Yes. Or previously operated ipsilateral neck. Yes, please go ahead.
So, Shruti, can you tell us something about compartment resection, what it is?
Yes, sir. Compartment resection, this idea is has been put forth by the Calabrese et al. Sir, based on the sarcoma treatment, where the tumor is removed in a compartment wise. And along with the primary tumor, the potential pathways of spread, like in the case of tongue, a muscular pathway and lymphatic pathway, vascular pathway, the glandular pathway, that is sublingual gland and submandibular gland. So these all which are the potential pathways of spread will be taken as a single compartment, living, so that even small microscopic foci of disease, because especially in tongue musculature as a possibility of tumor spreading along the muscle fibers, we will not be leaving behind the even microscopic foci. And so chance of loco-regional control will be better with the compartment resection.
So,
So
Shruti,
when
how
you
will
say,
it make?
sorry,
Go
man,
ahead,
go on.
Arjun. No, go ahead, Arjun.
No, I just want to ask, in what situation will you consider a compartment resection, and in what situation you think we should go ahead with a wide excision and a neck separate?
Whenever tumor is reaching the sublingual gland and tumor is touching the mylohyoid muscle, and or tumor involving the almost half of the tongue, I think these are the ideal indications for a compartment resection.
Anything in the neck? When you have any specific neck nodal burden or a higher neck nodal burden, you also think of, you would also think toward the compartment resection, because that entire part, the lymphatics would definitely be involved, right?
Yes, sir.
So you can also consider compartment resection when you have a high nodal burden with a small primary as well.
Okay.
Yes, madam.
No, I wanted to ask the same question. And maybe another indication can be if the disease is tracking along the neurovascular bundle, or there is a gross involvement of the neurovascular bundle.
Okay.
So there also, yeah, you want a clear margin on everything. So that is another indication where you could think of doing a compartment resection.
Okay.
So Shruti, you also mentioned you have better survival with compartment resection, right? Your last statement was that. So any evidence you have for that?
Yes, sir. Calabrese et al., after describing compartment resection, he did a study, which was a retrospective study. He compared the standard wide local excision with compartment resection, but he included including T2 stage of the tumor, sir. In that, he found that local regional control was better with the compartment resection, sir. 6.
Anything after Calabrese's paper has come?
Yeah, more recent publication and
Yes,
probably more robust evidence also.
this was done from Kochi, Amrita, I think, ma'am. There they compared, they did a propensity match. They did a comparison between the two things. That was also, I don't remember exactly, but there was one paper from Kochi.
Yeah, you are on the right track. You are on the right track. You are quoting the right paper. If you just remember the findings.
I forgot, ma'am. Actually, I have read it long back. But there is a paper by them, and they also proved that they did a match propensity match scoring and tried to compare between. It was a multi-institutional study from other institutions outside the India also were involved, but I don't remember findings, ma'am.
In that, they could not show the survival benefit with the compartment resection.
Okay, ma'am.
Yeah.
Okay, Shruti, one more thing, you counseled the patient, you told them about the, morbidity of the surgery, survival. Still the patient says, no, I don't want to do surgery. So what other options can you give this patient?
We can actually give him some time and offer neoadjuvant chemotherapy and subside the tumor. And again, whether counsel whether he's willing for surgery. One option.
Okay.
Second option is go for a definitive CTRT, sir.
Definitive CTRT. Okay. So which would you prefer, neoadjuvant chemotherapy or definitive CTRT? Because the patient will ask you in terms of survival, because both are non-surgical, both will save his tongue apparently. So which would you, in terms of survival, give the option to the patient? And by that I mean, of course, tell me the survival also that's quoted in the literature.
Neoadjuvant chemotherapy will be, I prefer.
Is there anything like this specifically for the tongue?
Organ preservation. Sir.
Can you tell me the indications of neoadjuvant chemotherapy in oral cavity?
Yes, ma'am. Neoadjuvant chemotherapy is indicated when, in case of buccal mucosa primary with peritumoral edema extending up to the zygoma or beyond the zygomatic arch, then anterior two-third of tongue primary extending up to the or beyond the up to the level of hyoid or beyond the level of hyoid, anterior two-third of tongue primary extending up to the level of vallecula. And then when there is a buccal primary with extensive skin infiltration, not buccal mucosa, in general, oral cavity primary with extensive skin infiltration, which will hinder the margin status, so getting the adequate margins. And one more.
But you didn't enumerate the one which you want to counsel the. No, you want to consider NACT in this patient, na? But it is not one of the indication. Is there any data to support NACT in this scenario? What Arjun was asking.
I think one for organ preservation study was done. Mandible, I know, ma'am. On mandible preservation NACT random trial is there in the TMH. There they proved that mandible preservation is possible with acceptable toxicity level and without affecting the overall survival. Upfront surgery versus NACT, ma'am. Organ preservation mandible. This was a randomized trial, open label trial. This one I know.
So what will you offer to this patient if you're not offering surgery?
Neoadjuvant chemotherapy and followed by adjuvant CTRT.
Not adjuvant, definitive you mean to say, because no surgery. If you do the surgery, what are the factors then you want in the histopathological report to decide the adjuvant treatment?
In the histopathology, I want to look at the size of the tumor, ma'am. Then metastasis to the node, then presence of lymphovascular invasion, presence of perineural invasion, then a number, if node positivity is present, number of positive nodes, and any presence of extracapsular invasion. Then I also look to worst pattern of invasion. And margins, sorry, one more is I think is margins, margins of the surgical margins.
So Shruti, what margins do you think you would take?
More than 5 mm, I will consider as a clear margin, sir.
No, you're going to be in the surgery, right?
Yes, sir.
During the surgery, are you going to aim for more than 2 millimeters, 2.2, where it's sometimes quoted? Will you aim for 5? Will you aim for 7? Will you aim for 1?
Well,
what will you aim for?
We in our institution we practice 1. With the scale we keep 1. While dissecting 1.5 centimeter gross margin, sir. And after surgery, in a gross specimen we can check whether the margin is minimum 7 millimeter or not, sir.
Okay, so in your institution, since you're saying 1.5 with a scale, correct me if I'm wrong, your mandible was 0.5 millimeters away from the tumor. So would you want to take the mandible in this?
No, sir, we can actually take the gingival mucosa as a margin in this patient.
Gingival mucosa. Okay. So it's actually the periosteum you're taking as a barrier more than the gingival mucosa if you are aiming for that. Okay. So why did you say 7 millimeters?
There is a paper by TMH Chaturvedi sir that when you measure on after resection the margin, if you they found that if the margin is 7 mm, then it is more likely to be a clear margin. If it is less than 7 mm, they advise to go for either revision of this margin, or we should go for a frozen section. There's a high chance that we might get close margins in that patient.
Okay, fine. And I mentioned 2.2 millimeters. Any idea about that? Any evidence? Because these are, very talked about evidence. So any idea about 2.2?
2.2 millimeters. There is one section. 3 mm to
Sorry, 1 second. I can't hear you. Someone's mic is on.
Okay.
Yeah, sorry, Shruti, go on.
I think one paper recently they told 3 millimeter of margin is sufficient in buccal mucosa.
Okay, so there's a paper from the MSK group, okay, which discusses 2.2. But you can read that later on. But see, the idea is, just to be clear that you can aim for anything greater than 1 centimeter or greater. But in pathology, the idea is to come up with something more than 5 millimeters. Okay. So think about the standard things more than 1 centimeter clinically. And why does that difference happen? Any idea? Why you aim for 1, but you end up with 7 or 6 or 5?
That's mainly because of the contraction, and after formalin fixation, there will be a shrinkage of the tumor cell. There will be shrinkage of tissue around by
Correct.
20 to 30%.
Correct. Okay. And any idea which tissue shrinks more, which tissue shrinks less? Any evidence on that,
Mostly muscle.
Yeah, sorry, go on.
Muscle fibers are more likely to contract compared to
More often than not, all our resections will have some muscle base in it. So buccal mucosa contracts more and tongue contracts less. Okay, there's a percentage also to this. So you can find that out also.
Okay.
So now when you said frozen section, if it's less than 7 or more than 7, you mentioned something in that area. You want to send frozen section from for the specimen, or you want to send the tumor bed?
Frozen
Or
section
both?
Specimen, sir, preferably.
Okay, why?
That from the specimen is more better than from the tumor bed, because tumor bed orientation can be difficult, sir, and even taking exactly the point where we want it might be difficult rather than taking it from the specimen. Specimen is easy to orient for a pathologist.
But eventually you'll have to revise in the specimen bed only, na? So how will you know where to go back again?
But specimen drive-in will be more useful, and if that is negative, we no need to go revise in the tumor beds.
Okay, fair enough. You're right. Specimen driven approach is a better approach. But why you should know is that when you go back, you are 3 times out of 10 times only going to go in the same place where you've actually intended to go. Okay, so this is a very old article by Kerawala. So you're going to be off by almost 7 times. So in general, do you think frozen section really helps improving outcomes?
No, sir. Studies have proven that whatever the first time margin we achieve, that is the best we can give for the patient, because the revision of the margin is more likely. Even after re-excision, they did not find improvement in the patient recurrence outcomes. So that highly indicates that the tumor is more aggressive. So revision will be much useful.
And is there some meta-analysis or something you can quote on this? Recent one, more recent. So there was a meta-analysis, Mustafa Bulbul. So you can also just go through that. Okay,
Yeah.
so your first shot is your best shot. What you said is right. So in which situations do you think frozen section will be very valuable?
No, just 1 second. This one more point
Madam.
I would like to add. So you made a point that if it is on the frozen section close, we revise, it does not help. So is it then you revise or you don't revise?
Is it?
If you have sent it for frozen and it is closed, so you will revise or you will not revise?
We will revise, ma'am.
You will revise. Okay, so it may not be as good as if you had achieved the clear margins in the first go, but it is definitely better than leaving behind the close margin.
Yes, ma'am.
Okay, so there are three categories: clear margin, close and revised, and close and not revised. Okay, so if you have a frozen and it is guiding you that you have compromised a margin, say 2 millimeter and 3 millimeter, and there is a possibility, better to go ahead and revise.
Yes, ma'am.
Okay, and now you have done the surgery. Histopath report, I think we have not discussed adjuvant at all. So, how will you decide regarding the adjuvant treatment?
Adjuvant treatment is decided based on the stage. One is stage, it's indicated in case of stage 3 and stage 4 tumor in the presence of perineural invasion, in the presence of lymphovascular invasion.
No, 1 second.
Yes,
Tell us the absolute first tell us what are the adjuvant options that you have, and then tell us the clear indications when will you offer what.
Okay. Absolute indication for the adjuvant treatment options are adjuvant radiotherapy, then adjuvant chemoradiotherapy, ma'am. Adjuvant radiotherapy is absolute indication is stage 3 tumor, stage 4 tumor, n plus the presence of the metastasis in the neck, 2 or more positive nodes, then presence of presence of perineural invasion, then close margins. These are the absolute indications for the adjuvant radiotherapy. Presence of extravascular extension and presence of positive margin is an absolute indication for adjuvant chemoradiotherapy.
Would you give the adjuvant radiotherapy in all cases with perineural invasion, or you would want to quantify or irrespective small perineural invasion seen, a small nerve seen, and you'll go ahead with radiotherapy in those cases?
If it is extratumoral and if there is a large nerve, it's a definite indication for.
Yeah, so you would want to quantify the perineural invasion. And what are the soft indicators of adjuvant treatment?
Sorry,
or intermediate factors for adjuvant treatment?
Intermediate indications factors are presence of LVI, ma'am, and so sometimes only there are all the other factors are negative and only the n plus single node is metastatic node is positive, and then worst pattern of invasion 4 and 5.
Would you consider grade?
Poorly differentiated tumor is grade of the tumor, sorry.
So if you have like if yours is an advanced cancer, so definitely he will need adjuvant treatment. But suppose it was an early cancer, so and you have these intermediate factors, so how will you decide in those cases whether to give or not, or you will give irrespective of everything? Say it's a 2 into 2 centimeter and with a lymphovascular invasion. So
in that case, one thing is we have to discuss with the patient about the advantage and disadvantage, but lymphovascular invasion I would give, ma'am.
only lymphovascular invasion as a high risk factor you will give. Any evidence to support it?
Yes, ma'am. LVI has been known, has been proven to that it increases the chance of recurrence and nodal metastasis, ma'am.
But then all we call the high risk factors like poorly differentiated, it is also associated with higher chance of local recurrence. If we talk about the worst pattern of invasion, 5 is even worse than when you're talking about a lymphovascular invasion, then there are other emerging factors. So every factor you will give radiotherapy?
No, not really, ma'am. But It's again depends on the number needed to treat. It will be, we are sometimes will be over treating these kind of things patients. Other option is to keep the patient on close follow.
Any paper, any scoring system, if you're aware about to treat these soft factors or intermediate factors?
No, I will read it.
Shruti, what is the dose of radiotherapy and chemotherapy that you would give in an adjuvant setting?
So in the adjuvant radiotherapy, sir, they will divide it as high risk area and low risk area. High risk area is the tumor bed and positive nodal area that will receive 66 to 70 gray radiation. Low risk area is like contralateral neck, which is the neck, which is negative neck. Those things will be given 56 to 60 gray, sir. And intermediate risk will be given 60 to 66 gray, sir.
Shruti, what is the difference in the dose for the adjuvant radiotherapy and a definitive radiotherapy? Is there any dose difference?
Is definitely radiotherapy, they will give you 66 to 70 gram, ma'am. But here we will be not whole, the bed will not be irradiated with definitive 66 to 70 gram, ma'am.
Any paper that you can quote about the adjuvant radiotherapy dosage? So there is a paper by Lister Peter. Please go back and read. In adjuvant setting, you don't go to 66 and 70 grays. It's for the definitive setting. For the adjuvant setting, it is 56 to 60 gray. And is there any time period, like when should the patient start the radiotherapy? How soon should patients start the radiotherapy? They will always ask you this question.
Patient should ideally start as once the wound is healed well, and there is that one, ideally within 6 weeks of the surgery, and the whole treatment package should be completed within 100 days, ma'am. Can be started as early as possible once the wound is healed well, ma'am.
And what is the dose of chemotherapy? And what chemotherapy do you give in an adjuvant setting, not definitive setting?
Yeah, adjuvant setting usually cisplatin and paclitaxel they will prefer, sir. Dosage cisplatin is 100 milligram per meter square, and paclitaxel.
Okay, read about this. Okay. Asim, should we continue?
I think we can wind up. If you have any questions or anybody has any comments, then we can just finish it off after that.
Yeah, Asim, can I ask one question, please? Yes.
Sure, sir, sure.
Okay. So, Shruti, what is the role of oral tongue in mastication and swallowing?
So mastication and swallowing tongue is the one which helps in pushing the bolus. From when the tongue is touches the hard palate, the bolus will get bolus will get move to the oropharynx, sir.
So the tongue has both
Also in
sense.
Hello. Also helps in food formation.
So, Shruti, what I wanted to ask is that can you please define the sensory and motor function of the tongue, how it helps?
One is tongue. By movement of the tongue, the bolus, it helps in the bolus formation, sir.
So what is the function of the sensory tongue, sensory part of the tongue? What is the motor function? How it is helping?
Yeah, sensory part of the tongue helps in taste sensation, whereas motor part of the tongue, which is mainly the intrinsic musculature, which are responsible for the tongue mobility, helps in the pushing the bolus. Helps in pushing the bolus to the oropharynx by touching the tongue, dorsum of the tongue to the hard palate, sir. and that way it will and tongue also helps in clearing the food which is accumulated in the sulcus.
It has been seen that despite the very extensive surgery of the tongue after losing some more than 50-60%, the quality of life of patients is not that bad as you expect. How it is possible for tongue cancer, tongue surgery?
Sorry, sir.
So, in spite of advanced disease and mutilative surgery of CA tongue, the quality of life outcome is not that bad as we expected.
Yes, sir.
The patient cope up with the new situation very promptly, and they eventually have some good quality of life. How it is possible?
Patients will not have good quality of life, mainly because of the thing is adjoint tongue mobility may not be as great as native tongue, sir. Then speech quality will be not as comprehensible as original tongue. Then also because of the adjuvant radiotherapy side effects like xerostomia, dryness of dryness, and burning sensation of the because of the and altered taste sensation. So these are the factors which contribute where patient will not be happy with in spite of the good surgery. And
Yeah, if you see the tongue cancers, usually both side of the base tongue is usually not involved, or we need not have to sacrifice both side of the tongue. Even if we say the total gloss, usually one side of the base tongue left. Okay. So eventually what happened in this kind of situations, the swallowing somewhat, some portion of this normal swallowing mechanism is there along with the reconstructed tongue. So the swallowing part remains somehow effective, even though not normal, but in comparison to speech, the swallowing function up to some extent it remains. That's why swallowing part little unaffected. Somehow patient manage to swallow things. Of course, for communication, speech is not there, not so communicable, but patients somehow make it manageable to communicate. But swallowing is fine. That's why, in spite of very advanced tongue disease or very big reconstructions, tongue cancers patients, eventually the ultimate long-term quality of life is not that bad. Okay, that's from my side, Asim. We can conclude, wrap up.
Yeah, Shruti, one last comment on the reconstruction. Given a choice of reconstruction to this patient, what will be your choice and why?
for this patient, my choice will be radial artery forearm flap, sir. Why is radial artery forearm flap is thin, pliable, and gives mobility will be better. And it is a donor two-team approach is possible. Donor side morbidity is less. Then it can the pedicle caliber is good, and pedicle length will be also can reach when the contralateral neck. The length will be good enough. And even sensation can create sensate flap with radial artery forearm flaps.
So, have you seen any sunset flaps done with radial artery forearm flap?
I have not seen, sir. I have not seen, sir.
Okay, so people have tried sunset flaps, but the sensation is not always there, or it is not always the way we want it, right? Asim, I think we can conclude.
Sure, sir. Yeah.
Thank you, Shruti. Well done.
Thank you, sir. Thank you so much.
So thank you so much, everyone. Thank you, Dr. Ashok Dasa, Dr. Dushyant Mandlik, Dr. Arjun, and Dr. Richa Vaish for joining, and thank you, Shruti, for this case presentation. So next week we'll be having a laryngeal session, laryngeal cancer, and we'll be discussing on conservative laryngeal surgeries in the era of organ preservation. So see you next week. Thank you all.
Thank you, Asim.
Thank you.
Thank you, Asim.